Good afternoon, and thanks for joining us for our PHSSR Research in Progress series. Our theme today is Bridging Health and Healthcare. The topic is the Public Health Information Technology Technology Maturity Index, a method for evaluating and enhancing public health information technology effectiveness. And I'm Rick Ingram from the National Coordinating Center for Public Health Systems and Services Research. Our presenters today are Rita Agarwal and Kenyon Crowley. Rita is a professor in the Robert H. Smith Dean's Chair of Information Systems at the Robert H. Smith School for Business, University of Maryland College Park. She's also the founder and director of the Center for Health Information and Decision Systems at the Smith School. She's published over 90 papers on information technology management topics in journals such as Information Systems Research, Management Science, Journal of Management Information Systems, and the Decision Support Systems. Is the editor-in-chief of Information Systems Research and has presented at numerous national and international conferences. Kenyon Crowley serves as Deputy Director of the Center for Health Information and Decision Systems at the Robert H. Smith Business, where he manages activities aimed at improving the design, adoption, integration, and effective use of information systems in healthcare to address outcomes such as patient safety, healthcare quality, efficiency, and healthcare delivery, and the reduction in health disparities. He's also worked with a wide range of government agencies, FDA, CMS, ARC, and commercial organizations. So, with that, Rita and Kenyon, would you like to start?
Thank you. Good afternoon, everyone. This is Rita Agarwal. Thank you for introducing me. So what I'm going to be doing today is to provide a very high 30,000 level description of the research that we've been engaged in almost the last couple of years, to give you an overview of some of our objectives and some of our findings, and also present the next steps ahead. Most significantly, for those who are participating in this webinar, we'd love your feedback to help us improve where this research is heading, because I think the kind of work that we're doing would really benefit from community input and from sort of crowdsourcing opinions on where we are. Let me first introduce the partners who are engaged in this research. Rick provided an introduction to the Center for Health Information and Decision Systems that I direct. We are fortunate to have a multidisciplinary team of experts who are working together on this project. My colleagues from the University of Maryland School of Public Health, who have done extensive research on understanding how to improve the health and wellness of communities, are part of the project. Primary Care Coalition of Montgomery County, Maryland, which is the setting for this study, and one of the executives on the Primary Care Coalition will be providing some input later in this webinar, is also a partner in the project. And then, of course, our focal county, that is Montgomery County, Maryland, is a close and very engaged and collaborative partner with us in this research. We're also grateful to the Robert Wood Johnson Foundation for supporting this research, which we think is absolutely critical at this time in our nation's health system history, and the National Coordinating Center for Public Health Services in the University of Kentucky. So I'm going to start with a little bit of background and motivation for the project, and lay out why we believe this research is really important. It is undeniable today that our public health delivery systems, with their emphasis on meeting the needs of vulnerable populations, they face multiple systemic challenges that have limited their ability to effectively achieve their mission of ensuring the health and wellness of all members of the communities they serve. The focus of our project is on one specific systemic challenge, and that is on the technology and data that might constrain the optimal delivery of public health services. As we look across all the counties nationwide, there is no one single system that links all public health agencies and stakeholders, and in the absence of such, clearly interoperability is a major challenge, as is the exchange of information. Most critically, there is limited integration and care coordination across a range of services related to somatic and behavioral health and social services. Citizens find themselves having to navigate a very complex maze of service encounters, each of which represents a disconnected episode. Likewise, health professionals are unable to offer the best and most optimal advice and care simply because individual service facilities operate in silos with limited exchange and visibility into the health data of individuals. Now, as you can see, this not only poses an efficiency challenge in terms of the cost of care and the amount of time that's spent searching for information, but also to the extent that the providers don't have a complete health history of the individual, it can also jeopardize the quality of care that can be delivered. Today's public health systems face a bewildering array of choices that they need to make around technology. Well, we all believe and we all understand, and a lot of the national discourse on health information technology supports this belief, that electronic medical records and other types of health IT can play an enormously important role in improving the delivery of public health as well as health across all various aspects of the economy. There is unfortunately a lot of complexity and a lot of confusion around the technology choices, the appropriate strategies to guide these technology choices and investments, and what types of policies we need in place to enable this infrastructure. The policies could be related to privacy, to data security, to information sharing, etc. While we have the opportunity to leverage our data and information systems more effectively, there's a lot of investment that's going on and there's unclear return on investment. So what we are aiming to do with this project is to uncover, if you will, some of the value generation processes for public health information technology. Broadly speaking, we want to try and understand what does it take to convert public health information technology investments into real value. And by real value, we mean payback for all the citizens of the community so that they can get access to better health and they can get access to better quality of service. Our project has 3 specific aims. Each one of them addresses that broad objective that I just articulated. First aim is to assess the implementation of an electronic health record system designed to better integrate public health and primary care delivery systems. As I noted earlier in the background and motivation for this research, we do operate in silos, and these silos get especially complex across public health facilities that might sometimes be resource constrained, that might sometimes be in areas of the county that are less connected to the rest of the services, etc. So we want to generate some insights about the lessons learned, the best practices, and the pitfalls to avoid as we study the implementation of the EHR so we can inform the efforts of other counties. Number 2, we want to be able to produce evidence that allows us to measure the types of outcomes that these public health IT investments are creating. I pointed out earlier that the return on investment is unclear. It's difficult to persuade policymakers and other legislators to allocate resources to this important area unless we have clear and compelling evidence of outcome. We want to be able to measure and document the effects of this EHR, specifically for integration of information and services across disparate facilities, and with a particular focus on behavioral health management, because that's one of the areas that are less understood and less studied. Finally, our third objective, and we will be spending time on aims 1 and 2 today and sharing some preliminary findings. Our third aim is to develop a tool that can serve as the foundation for helping counties across the nation assess, measure, benchmark, and improve their value extraction from public health information technology. We call this the Public Health IT Maturity Index, and we hope that over time this becomes an outstanding foundation for public health services across the entire nation. So I'll move on now to aim 1 and share some preliminary findings. Recall that aim 1 was to assess the implementation of the EHR. We were fortunate to launch this project at a very unique and opportune time in Montgomery County, Maryland. The Department of Health and Human Services, during the performance period of this project, has just completed the implementation of an integrated EHR that combines together social services with behavioral and somatic health. Simultaneously, a little bit before the Department of Health and Human Services, Primary Care Coalition of Montgomery County also implemented an electronic medical record across all of its safety net clinics. And as we speak, these two electronic medical record systems are in the process of being integrated so that we have a single system that ties together the entire ecosystem of facilities. For AIM-1, our goal was to try and understand exactly how the users of the system felt prior to the implementation, and to get some insights into what their pre-implementation expectations are and what are the kinds of challenges that might be experienced during implementation. And we would follow this up with post-implementation data collection as well. For the pre-implementation, we have a very rich and robust set of data that combines both qualitative and quantitative measures. We conducted 46 interviews, 50 sets of observations in 2 focus groups of 15 individuals each. And we have close to 400 respondents to an extensive survey, and I'll share some of those findings next. The constructs for the pre-implementation survey that will be repeated on the post-implementation survey were informed by extensive research that our team has done in the past on looking at and studying various types of IT adoption, including health IT. And here we were trying to capture the attitudes, beliefs, expectations of the individuals who were facing the implementation of this new disruptive technology in their work environment. We measured a number of different constructs, information strengths, gaps, that is, what is it about the current information environment that's good, and what is it about the current information environment that creates some concerns for users. We also wanted to get a sense for exactly what the expectations are and the attitude of the users towards the impending EHR, and whether in fact that attitude was positive or negative, the perceived usefulness and ease of use of the incoming EHR, to what extent the individuals planned to use the EHR in the future, how well they felt they knew how to use the EHR and its general capabilities and functioning, and then finally the support environment. In other words, what kinds of training did people receive, and was that training adequate? Some high-level findings from the pre-EHR implementation survey analysis. And what you'll see on this slide and the next slide is the distribution of research variables across the 2 primary organizations where the EHR was implemented, the Department of Health and Human Services and the primary care clinics. Just a quick overview of the data that is in this slide. We can see that each one of the research variables is fairly evenly distributed across the entire range of responses. The means are right about where they should be, but we can also see from this slide that people have robust expectations about using the EHR in the future, and they also have fairly positive expectations about EHR impacts. So that's good news. So pre-implementation going into this transition to a new electronic environment, we have positive attitudes and beliefs from the users. I want to contrast this with the early implementation surveys that were done at PCC. Recall that in PCC, the EHR was implemented a little bit earlier than in HHS. And we can see over here that a lot of the responses are lower than the responses for DHHS. So this is not surprising in some ways, because these users were experiencing the early frustrations that one might expect when any new technology comes in. So there are startup costs, there's a learning curve. We hope and we expect to see that all of these will improve as time goes on and users adjust the technology and their workflow to adapt to each other. But we can't say that for sure, but this is something that we're monitoring very closely. We will be following up with an identical survey 3 months after each implementation has been completed, and since we're able to match responses across different manifestations, this will allow us to specifically see how the attitudes of individual users have moved. Moving on now to the qualitative data, there's a lot of detail on this slide and the next couple of slides that you all can read at your leisure. But I just want to highlight that in our qualitative interviews as well as our observation, there were specific and detailed challenges that came up as individuals spoke about their experiences and their expectations and their beliefs about the EHR. There was a number of concerns related to the use of information. There were many references to coordination gaps. Again, this underscores the importance of this project and the motivation for having greater integration and coordination across all these facilities. As you can see from this quote from a psychiatric nurse at a substance abuse clinic, when a person comes in, we do a complete biopsychosocial. So it's at that point that we identify medical needs, psychiatric needs, social needs, housing needs, financial needs. We identify all of these. But we somehow need to be able to link up these services, that the social services available in the community to all of these needs. On the good news front, there were positive expectations that were reflected in our survey as well. A behavioral health staffer noted, I look forward to having the electronic records here in the government because it's needed and it will be more efficient. So both from an effectiveness and efficiency perspective, our users are looking forward to new EHR. To summarize some of the early implementation issues that surfaced, people do have difficulty getting access to the information that they need. They don't have difficulty getting access to the system, but they have difficulty extracting information from it. Unfortunately, there is a perception that the promised integration is less than ideal. EHR systems still feel as though they're designed for a single practice, and then within those practice into single silos such as clinical and behavioral, and that there are not enough customized capabilities for the unique needs that behavioral and public health services desire and need to have. So for example, there aren't enough customized templates to be able to produce the type of reports that behavioral services require, enough customized templates to be able to produce the types of reports that individual users require. Some of the technical staff were frustrated by the limited configuration capability of the EHR because clearly every implementation site is unique in some ways, and they'd like to have the ability to tweak the tool to meet their workflows and their needs the best. I also want to underscore that even though I've highlighted a lot of negative issues, there were several comments and remarks and observations about positive aspects of the EMR. There is additional visibility being gained into the data. So for example, Montgomery County is now able to track how many people are being served, what kinds of services those individuals are getting, and over time they'll have a better understanding of how their resources are. In AIM 2, we will be measuring and documenting the effects of the EHR through behavioral health case studies and also using some quantitative archival data. Our primary method of analysis would be through observation and interviews again. And we've identified 4 specific use cases that we're going to dig deep into as case studies of integration across behavioral health and social services. Specifically, we will be looking at the homeless with chronic conditions and severe mental illness that is referred to in the literature and in policy discussions as the frequent emergency room flyer. We'll be studying mental outpatient counseling services, medication management of mentally ill, and then population management, surveillance, and for behavioral health. Now I will turn it over to my colleague, Kenyon Crowley, who's going to talk about AIM 3.
All right, thank you very much, Rita. Well, good afternoon, everyone. It's my pleasure to be here with you to talk about this work that we've been doing over the almost 2 years now with some great partners in the community. So specifically, I want to talk to you about AIM 3 and the sort of process we're going through to get there and where we're at. So in developing a public health IT maturity index, we took a couple different approaches. I mean, the use of maturity models and indexes within the IT literature is not new. I mean, since the 1970s, I mean, starting with sort of Richard Nolan and others, there have been a lot of work done to understand what are the facets of information technology that lead to value production in different systems. Within the healthcare industry itself, there's also been some specific applications of these systems. I mean, notably, you may have seen HIMS, electronic medical record adoption model, which has been around for almost a decade now and used by many hospitals. The National Health Services in the UK has their own specific adoption model for the goals that they're trying to reach. And there are several sort of related examples of this. I mean, to date, there's been less use of some of these maturity indexes and models applied specifically to public health, although that there is some great work being done by some multi-stakeholder groups that were leveraging folks such as the Institute of Medicine and their Public Health IT Task Force has been pointing to some of the gaps and needs within the public health IT space. The National Association of County and City Health Officials, NACHO, and along with their partners at NORC, have been examining public health IT systems and producing some good findings that point to areas that need addressing by health departments. As well, there are some tools. The Public Health Informatics Institute has been working on some documentation to help health departments and others sort of assess and build capabilities. So this next slide gives a snapshot of the initial draft model, and I will underscore that this is the initial draft model. While it's built on a solid base of literature, as well as what we've learned through talking with experts in this space, and then looking at the needs of health departments. I mean, notably Montgomery County, but within discussions with others, these four high-level categories provide the basis for the model, and I'll briefly go through each one of these categories with you. So when we talk about scale and scope of public health IT use, this refers to the nature of use and the extent of use. The nature, and I'll forward this slide before I go through. So the nature of use refers to the types of systems being used, the types of data that are being communicated electronically. We base the systems off, there's been some good work recently by Olson and Bosch on sort of the five sort of categories of information systems in public health, including administrative systems, surveillance systems, electronic health record and practice management systems, registries, and digital consumer resources. Now, when we talk about the extent of use, this is really how broad and how deep the use of IT is across the health department. And I'll show you a snapshot of the model. This is just a piece of it on this next page. But when we talk about the breadth and depth of use, we're basing this within the foundational services of public health. Underscored by the foundational capabilities, which are the basic programs no health department can be without, as well as the foundational areas, which I won't read them out to you because you can see them here on the screen. But the degree to which they're able to use these, or to use information technology across these different areas, and we also bucketize it by which types of sites are being able to use it. So at early levels, it's the clinical sites, but as we sort of proceed in maturity, we see additional utilization of these tools by both the behavioral health sites as well as the social services, the human services sites. So this is a snapshot, an even smaller snapshot of the model here. Here for a second. Now, when we talk about the next dimension, which is public health IT quality, we're really talking about the degree of excellence embedded within the systems. And the subdimensions of this element include the system quality, the information quality, the standards and interoperability, as well as privacy and security. So when we talk about system quality, I mean, these are things such as ease of use, how useful the system is, user satisfaction with the system, reliability, and maintenance. When we talk about information quality, this refers to the availability of relevant information, how accurate that information is, and how timely the delivery of that information is. And the next subdimension of privacy and, of standards and interoperability speaks to, I mean, how thorough the health department has been in sort of first having appropriate standards for the different service areas that they need, the different systems that are being used, and then as you progress in your maturity, how well those standards are being used within the systems. The measures which are used to gauge a standard's maturity are based off of, again, HIMSS has done some work to define sort of interoperable systems based on you sort of starting at a foundational level when data can transfer from one system to another, but the receiving system is not able to interpret the data, moving up to structural, which is an intermediate level, in which the format of the data exchange has been built into the system such that the purpose and the meaning of the data is preserved and unaltered. And then at the most mature level within interoperability, we start talking about semantic interoperability. So that's at the highest level. That's when the structure of the data and how it's codified with the vocabulary is used is such that both that the receiving system can make sense of it and compute it and apply that, and then also speak with the sending system. So that level of interoperability is the goal that's sort of shared across the Office of National Coordinator and other sort of groups that are trying to advance health information systems in our country. The meaningful use requirements, for example, build in specific standards and measures towards this degree of interoperability. The last subdimension in the PHIT quality domain is privacy and security. And when we talk about privacy and security, it's maturation from first sort of having appropriate policies embedded to systems that have embedded these within them to allow for a very secure environment. And also as most people on this webinar probably know is, there's a variety of service area types within the public health system that have different privacy and security requirements, such as behavioral health versus somatic care. So to the extent that systems are flexible in their privacy and security policies to allow for the exchange of data and the management of data, that is a element of their maturity, and we have some specific elements within the model that speak to this. The fourth dimension, the third dimension of the Public Health IT Maturity Index has to do with the digital literacy and competencies in public health IT. So this is focused at the community and at the workforce level. I mean, essentially, you must have a certain set of skills that are embedded within the community and within the workforce to make the most use of these systems. So we look at the digital literacy level in the community, the amount of digital literacy training and whether it's used, and then within the workforce itself, are there training programs for staff that are appropriate? Are they being used, and do they provide for the type of continuing education and competencies that are needed? And one thing I'll note as we continue through the model here, so it's important to note that some dimensions within the model are directly modifiable by health departments, such as their selection of systems for different purposes. Now, such things as a community digital literacy, which can be measured through an adult literacy rate and gross enrollment ratios, those are a public health department has less ability to influence those, but as part of the sort of wider set of elements that provide for a mature community to be able to do that, they are important elements. So when we start talking about how to sort of score and measure using this model, you'll see that the weighting of the different elements will be reflected in this. So going to the fourth category of the index, so this has to do with community digital infrastructure or how wired a community is. And to the extent that a public health ecosystem has partners that have implemented digital systems that can exchange data with them, system provide that, because as you know, I mean, a public health department organization doesn't exist in an island. It takes a wide ecosystem of partners to achieve optimal results. So the way that we measure community digital infrastructure is across the internet, actually go to the next slide, but is through the internet access and use in a community, the amount of IT budget that's allocated and available towards IT, as well as community partner infrastructure. So the hospitals in the community that are wired, that'll influence the maturity of a public health IT system, as well as health information exchange, having sort of connections to the HIA and be able to flow information across that. And then the sort of final element in this category has to do with open data and innovation. So to what degree has a public health system enabled the community around them to operate as a learning health system, so that entrepreneurs and innovators might have data, might be able to create systems that can support health and wellness, literacy, these things. And we note that, I mean, this is far along on that public health IT maturity journey, but you see some nice examples of sort of open data about public health systems cropping up around the country. Chicago comes to mind with their open health portal. New York City has put a lot of investment into this, is doing well. But there's others. It's not just the big sort of cities and jurisdictions can do that, but there's tools and services available now which enable privacy appropriate movement of data from the health IT infrastructure into the community to be used by researchers, innovators, community members. And this is also a sort of area of high interest for Health and Human Services, and so there's programs to support that. So moving on, so having covered the four major elements of the maturity index, I want to speak for a minute about what are the data sources to enable computation of and benchmarking. So this is a snapshot from the public health IT quality domain, and so you see, I mean, many of these categories will require primary survey data from users within the department, but there's also some secondary data that can fulfill the needs of some of the categories, such as the standards, the types of interoperability that have been enabled. And I think one of our next steps in terms of the research too, as we sort of move beyond Montgomery County and helping sort of measure these types of data sources, will be sort of codifying the specific data collection instruments to be able to enable this. Because one thing, I mean, we're very cognizant of is, public health departments and others are asked to fill out a lot of forms and do a lot of things. So I think one of the main things that we want to do is find what's that sort of most succinct but still sort of useful, meaningful instrument to enable this collection. Because I mean, we're really excited that, I mean, from a collection and a sort of a measurement methodology such as this, you can start having comparisons across different groups. You can benchmark what's working in one community. You can start tying in outcome measures. And that takes me to our next step slide. So as Dr. Agarwal mentioned, so the final EHR implementation at Department of Health and Human Services was July 7th. So we'll be leading into some of the post-implementation data collection analysis in the October timeframe. We are currently undergoing a Delphi study with this initial maturity index. We have a number of experts across the country in different roles, from researchers to public health practitioners, to public stakeholder representatives, and others that are providing feedback on this model. And as Rita mentioned, we do welcome your feedback as well. And on the next slide, I'll provide some mechanisms for you to do that. And we plan to finish this phase of the project by February 2016. And then as we look to the future, begin some comparative assessment of public health IT maturity across different systems. So we ask for you to engage with us. We have a project blog that's available where we'll be posting results as they become available. You can follow along. We've also put this initial model, which is not the narrative, but the initial model's Google spreadsheet is at this address listed on your screen, and with the comments enabled. So we welcome any and all comments, smart remarks. So please engage with us. And if you want to engage with us on social media, we're at Health IT on Twitter, or there's our email address. So with that, I'd like to turn it over to our first commentator, Dushanka Kleiman, unless Dr. Ingram, you have any comments before we do that.
No, normally we just start with the commentary. So our first commenter is Dushanka Kleiman, who's Associate Dean for Research and Professor in the Department of Epidemiology and Biostatistics at the School of Public Health, University of Maryland, College Park. She has 28 years of government service, where she most recently served as Deputy Director for the National Institute of Dental and Craniofacial Research, NIH, and Assistant Surgeon General, U.S. Public Health Service, Commission Corps. So Dushanka, do you have some comments for us?
I sure do. Thank you very much for that introduction. And I'm giving my comments from the perspective of the value from a public health perspective, clearly, and also implications for future research. So from that perspective, the centerpiece of the value of this work that I see is in building and testing the effectiveness of IT solutions to support integration of public health programs in primary care, in this case with community health centers. Ultimately, as has been said by Dr. Agarwal, this would help streamline and coordinate care and create efficiencies and, of course, reduce the redundancies that we in health, and ultimately help save time for program directors, clinicians, and patients, and, of course, their families and caregivers. I see this project as representing essential foundational work in the integration of these two silo areas, a process that really needs very strong grounding in the clinical environment, but then needs to grow effectively and efficiently to expand into the integration of surveillance systems and cross-sector communication and coordination as we recognize the critical nature of social determinants of health. This project focuses on two of the research questions under the Public Health Information and Technology theme area of the Public Health Services and Systems National Research Agenda. Let me just highlight those. One is, how do information data systems, in this case the EHR specifically, affect the structure of public health delivery systems, particularly regarding integration and coordination with clinical healthcare providers? Secondly, how do health information and communication technologies influence efficiency, effectiveness, and outcomes of public health strategies delivered at all three levels, local, state, and national? And as these questions imply, and the research to answer these questions, use of information and communication technologies is critical. The Institute of Medicine report on primary care and public health highlighted the critical need for this integration, and also for health promotion purposes and overall population health improvement. That report defined integration as the linkage of programs and activities to promote overall efficiency and effectiveness and achieve improvement in population health. When I look at this project by its very design and implementation, It provides an experience at a local level in linkages between programs and activities, and it is generating data relevant to several key principles for a successful integration of public health and primary care. For example, there's a project-specific alignment of leadership across disciplines and programs that share a common mission. That's so essential in reducing fragmentation and supporting continuity of care. And the fact that this project moved in at a really early stage at the launch of this IT initiative across these different entities is very, very positive. Secondly, community input and engagement has been incorporated. And finally, the project includes the development of a tool that could be used to assess the capacity of different health information technology systems to share data and analysis. This type of tool is key to sustainability and contributes to healthcare improvement and integration. Development of this maturity index with input that has been solicited, and I appreciate that type of input from everyone in the community, it adds to the performance measure toolbox that we have and our capacity to monitor quality and ensure accountability. At the same time, this project addresses behavioral health as a case in point. This category of our healthcare is deeply fragmented, as has been noted, greatly contributed to health disparities, both independently and as a comorbidity. And it's especially complex in its contributing workforce providers and reimbursement mechanisms. So there's much to learn. Let me just turn to the implications for future research. This project focuses on one of the four thematic areas in the Public Health Services and Systems National Research Agenda, but it clearly has implications in other theme areas as well and beyond. First and foremost, the outcome of this project has a natural research trajectory that includes expansion and testing of the approach and the maturity index in other jurisdictions within the state and beyond. This expansion will allow for further refinement, testing, and possible subspecialization of a tool that assesses and improves IT investments. It's critical to have such a tool, especially given the many creative and costly modifications many sites are taking without the means to evaluate their effectiveness. The project also lays the foundation for the opportunity to collect data to perform a comparative assessment, as Kenyon has said, of a public health system's IT maturity in relation to other systems across the country. Secondly, while this project focuses on behavioral health as a case study, healthcare delivery systems focused on other conditions have also been segregated from traditional primary care. Expanding studies to explore the use of enhanced public health information technology maturity for other conditions, such as is my own bias, oral health, dental health, it opens up another category of research inquiry and application. Finally, this project has implications for research mentioned in other thematic areas of the National Research Agenda, such as the question that's actually in two areas, both in the health information and technology theme area, as well as in the public health system structure and performance area, which is how do disparities in access and information and communication technologies among public health practitioners and communities they serve affect the effectiveness, efficiency, and outcomes of public health strategies, particularly with a focus for racial and ethnic minority and low-income populations. Then also, due to the development of the Maturity Index and its further evolution, there are implications for research related to public health financing and how investments in public health delivery systems and supports impact the outcomes of public health strategy delivered at all three levels of local, state, and national, and what criteria are to be used to decide among investments or determine continuation of investments. Lastly, this project, as Kenyon has mentioned in one of the component parts of the index, has implications for the theme area of public health workforce. How do the skills and competency of the public health workforce in HIT impact the effectiveness and outcomes of public health strategies? What models of education and training are most effective? So I think this is an extremely exciting area that we are just in the beginning of, and I'm very appreciative of the opportunity to see the concrete development of ways in which to assess and monitor this evolution for the benefit of the public's health.
Thanks so much for those comments. Ritu or Kenyon, do you have any response to those? Anything you'd like to say in response to Dushanka's comments?
At this point, we'll wait until Tom has finished his, and then maybe we'll comment together on our comments.
Great. So our next commenter is Thomas Lewis. He's the Chief Information Officer of the Primary Care Coalition of Montgomery County, Maryland. He spent many years building and managing high-end patient care and clinical research information systems at the NIH Clinical Center, the Research Hospital, the National Institute of Health. So, Thomas, would you like to give us your thoughts?
Tom, you may be on mute.
Thomas, are you there?
I'm sorry.
Hello? You seem to be a little bit muted still. Could you speak a little louder, maybe?
Okay, let me take it off the speakerphone and speak this way.
That's perfect.
My perspective for today's discussion is from that of a safety net primary care provider treating low-income, often uninsured, culturally and linguistically diverse families and individuals. I'll touch briefly on really three major topics. One is public health as a systems integrator. The second is the Montgomery Cares experiment, and then barriers that I see to the adoption of some of the systems and goals that have been talked about earlier. One of the biggest challenges for safety net providers is timely access to relevant information from multiple sources presented in an easy-to-use format. In addition to medical issues, a patient may be homeless, living in substandard housing, may be receiving food or income support, may be in an abusive relationship, receiving county or other kinds of behavioral health, addiction services, a variety of public health services as well. Knowing this information at the time of care, as others have commented, can lead to improved outcomes, and conversely, the lack of such knowledge can be detrimental, delaying or preventing appropriate interventions. An environment that's able to consolidate and present this kind of information is potentially hugely valuable. Starting from the safety net provider end, a simple way to conceptualize this data is one or more additional tabs in a typical EHR that portrays each of the additional kinds of information. Now, a specific example might be a low-income diabetic patient. If the provider knew about the eligibility for food stamps or food banks or had access to related kinds of community information, they would be in a much better position to manage the diet, manage the disease, and manage the overall health status of the patient. A high-level way of measuring public health information systems would be its ability to acquire, synthesize, and distribute this kind of information. So that would be an encapsulation of, in my notion of a single measure of what Kenyon described in some detail. Touching on the notion of public health as a systems integrator, and here I'm coming from really a lot of my own background doing systems integration with the Primary Care Coalition, where we started with a group of a dozen or so safety net clinics in the region that barely knew about each other, and our goal was to bring them together into a system of care, linking them with essentially a web-based open source EHR that would allow them to share patients and share data, share services. When I think of public health as a systems integrator, initially I think of 5 community-wide kinds of activities, integrating primary care, especially safety net care, behavioral health services, social services, traditional public health services, and then increasingly distributed and coordinated case management in the community. You think of the challenges of a safety net patient receiving care in the clinic, then perhaps ending up in the ER, perhaps ending up in the hospital, being discharged back into an environment that was often unstable to begin with. You find that in practice there are different care managers at different sites that really have no effective way of communicating. So that's one of the elements that I think of in systems integration. To touch a little bit more detail on the Montgomery County experiment to help those on the webinar recognize perhaps more precisely what we're trying to do in our work. The first element, as I mentioned, was transforming the independent safety net systems into clinics into a system of care while still maintaining their independence and unique focus. Many of them are culturally or religious-based, have a focus on a particular subpopulation, and yet really need to focus as an integrated entity. And that process is perhaps 10 to 12 years old now, with a recent shift in medical records that Kenyon and Rita were able to help us approach in a more structured, evaluative way. The second is the more recent Montgomery County DHHS implementation of an EHR. And that's an interesting, unexpected natural experiment for us, in that the original intent was that the safety net clinics and the Health and Human Services public health clinics would share the same system. For a lot of complex reasons, it didn't work out that way. So there are two high performance but independent safety net clinic or EHR systems that we're now thinking about extended integration data sharing services for. So I think that's an accidental opportunity, but an important one in terms of the work that Kenyon and Rita are doing. The third is work internal to the Health and Human Services Department on their no wrong door social services policy. Part of the prerequisite for integrating more broadly is the integration activity that they're undertaking to bring their multiple social services together. And that leads to the fourth key part of the experiment, is a conceptual and then deliverable framework for sharing primary care, social services, behavioral health services data across multiple providers. I'll just touch briefly on barriers. One is that many EHRs have at best limited behavioral health capabilities. Neither of the systems that we put in had pre-existing PHQ-9 or GAD-7 scores, for example, and that's pretty basic stuff for primary care these days. Also, when a provider learns one EHR, it doesn't necessarily help them learn the next EHR that they're exposed to. The diversity in design and user interfaces for them are really quite primitive and inconsistent given the amount of time that they've been around. You also see fragmented pockets of data, EHRs not connected to health information exchanges, traditional freestanding registries that, from my perspective, just add a lot of cost, duplication, overhead. Often registries try to grow themselves by adding the kind of content that you would normally find in an EHR. So one evolutionary aspect would be, could an integrated public health system, information technology system, actually eliminate the need for independent registries? Impediments to data sharing are sociological as well as technical. Lots of fears about sharing behavioral health data, even more fears about sharing social services data, even when the technical and legal barriers have been addressed. And this is in spite of an increasing body of knowledge that says that those patients are quite willing to share data as long as it can be protected, because they recognize the value of that data sharing to their own health care. And we see that even in immigrant populations where you might expect the fear to be much greater. Kenyon touched on the cost and complexity, as did Rita, of new systems and systems migration. Data migration from one system to another is still difficult, expensive, and typically not done. And then I think as a final note, I'll just mention often the lack of perceived benefits to community-wide or population-specific integration. I think all of us see it from the professional point of view, but it's often not viewed as a value from, if you will, outside our community. I'll stop there and at least leave a few minutes for questions. Thanks.
Thank you so much. So Kenyon and Rita, do you have any kind of response to those comments?
We appreciate the feedback that Dishanka and Tom have provided, and I think in our mind it helps underscore the motivation for the work. I think the issues that Tom brought up around the integration of behavioral health and the challenges that surround it are absolutely critical, and we look forward to final results from this project that we hope can address some of the challenges. I think hearing from Dishanka, who is a public health expert, and from Tom, who is in the trenches dealing with the EHR implementation issues, has been incredibly valuable for us. So thank you.
Great. Thank you. It looks like we are about at 4 o'clock, so let's wrap this up. Thank you both again. Well, thank all four of you again for your participation today. Please give us some feedback. Tell us what you think. You can provide it at the web address on the screen right now. Archives of all the webinars available at the address below. We have a few upcoming webinars coming up. We've got a few on tribal public health, one on the randomized control trial to increase adolescent immunization through vaccine provider best practices. Also some food contamination ones. Again, tell us what you think at the web address on the screen. And if you need any more information, please feel free to contact Ann Kelly at the web address below. Thank you very much.
Well, thank you, everyone, for joining us today. And we have a few minutes. I mean, if there are any burning questions from the group, we'd be happy to entertain those. Or if not,